Okay. It's just setting up the meeting.
Okay, perfect.
Okay, great. Hi, everyone. My name is Sophia. I'm a new face here. I am one of the guest hosts for Aaron and Isis for whenever they can't host a meeting. So it's nice to virtually meet you all. So today we are honored to have Dr. Menka Patel, an ophthalmologist, as our guest. Before she gets started, remember that at the end, the Google form for you guys to fill out will be posted in the comments as well as our Instagram. So with that being said, Dr. Patel, you can get started whenever you're ready.
Okay, perfect. Hi, everybody. My name is Menka Patel. I'm excited to be invited for this talk and to give you guys all an idea of what ophthalmology is. So I'll go ahead and give a little bit about myself. I am an ophthalmologist, of course. I went to medical school at George Washington University. I did my intern year at Woodhull Medical Center, which is in New York. I returned back to George Washington for 3 years of ophthalmology residency and then returned back to New York to Columbia University for a 1-year cornea specialty. I'll talk a little bit more at the end about ophthalmology and answer any specific questions you guys may have about ophthalmology. I know it's a field that has limited exposure during medical school and definitely in pre-med as well. But I'm going to start off by going into talking about the anatomy of the eye. I know that this is, again, limited exposure, so I apologize if I'm kind of belaboring certain points, but I just want to make sure that we're all on the same page before we get started with a couple of cases. So this is a cross-section of the eye, and if you can see my pointer here, I'm going to be pointing at different parts of the eye. So this clear window in front of the eye is the cornea, which is my specialty. Behind that will be the colored part of the eye, which is the iris. The center part is called the pupil. Then there's the lens. Once we make our way further back, this is going to be the retina. The macula is right over here as well, which is where we get our sharpest vision. And then the optic nerve. And then I have this cross section here because I'm going to be focusing more on the anterior segment. So the anterior segment is just this part that's kind of boxed in. And cornea specialists tend to focus on the anterior segment. So the cases that we're going to cover today are all going to be dealing with the anterior segment. If we look here, this is the lens, then we make our way forward. This is the colored part of the iris. The center opening is the pupil, which changes with light and dark exposure. And then this is the clear window, which is the cornea. Now the cornea is, again, my specialty. It's got so much pathology that you wouldn't even imagine. And with ophthalmology, there's actually several subspecialties. There is cornea, which would be my specialty. There's you could also have specialties such as neuro-ophthalmology, retina, glaucoma, uveitis. So there's a lot of specialties. And then there's a specific specialty, pediatrics, which would work with mostly children. So for me, as a cornea specialist, I actually have elected to work with adults. But you could, if you're a cornea specialist, can do pediatrics, you can do adults, or you could just do cornea specialty with adults. And while we go through this, if you guys think of any other questions about the fields, just go ahead and send those over to me. So ophthalmology has its own language, and this is something that you kind of get thrown into when you start residency, or if you're doing a rotation in ophthalmology, but I kind of want to put it out here. So in case you guys come across any cases or read ophthalmology notes, this will kind of help you understand what we're talking about. So the first one here, OU is actually both eyes. OD is the right eye, OS is the left eye, CL is contact lens, SCL is soft contact lens. We use K for cornea, VA for vision, AC is for anterior chamber, and IOP is for intraocular pressure. This is just kind of a brief exposure. There's a bunch of other acronyms that we use. So if there's other ones that I may have on the slides here, I'll try to explain them along the way. So we're going to start off with case number 1. This is a patient that came in saying that my eyes are always red and burning. This is a 45-year-old female. She has a history of soft contact lens use for 10 plus years. She denies any overnight use. She's complaining about redness, burning of both eyes, and that's been going on for a few days. She's also complaining of intermittent blurriness. She denies any trauma, no new makeup, no other changes. She has a past medical history of just contact lens use. She's a social drinker, but otherwise everything else is pretty normal. So we do our examination, and this is kind of what you'll see for most examinations in ophthalmology. Vision and pressure are kind of our vitals. So whenever an ophthalmology resident is taking a consult, or you're presenting a patient to an ophthalmologist or consulting them, you always want to provide them with a vision and pressure, because that's our vital signs. It's going to give us so much information about the patient and what's kind of going on before you even start presenting. So the vision here is 20/20 in both eyes. The pressure is 16 in both eyes, and that's a normal pressure. Normal pressure generally tends to range from 10 to 21. Each eye can have a different pressure, but generally it's within about 2 to 5 points between the two eyes. Then we're looking at the lids and lashes, and there doesn't seem to be any abnormalities there. We look at the conjunctiva and sclera, and we notice that the eye is diffusely injected in both eyes, about 1+. The anterior chamber is deep and quiet. The cornea has evidence of diffuse superficial punctate keratitis in both eyes. And the dilated fundus exam, which is GFE, which is looking at the retina at the back of the eye. And that's when we kind of assess, is there any retinal pathology? Is there any optic nerve changes? And that's actually all within normal in this patient. So for this patient, given that everything is normal except for this corneal finding of superficial punctate keratitis, I'm leaning towards a diagnosis of dry eye. This is actually extremely common within my practice. I tend to see a lot of patients with dry eye, and dry eye is actually fairly common. I'm going to discuss that a little bit further. Other things that could cause a similar picture could be allergies, but I would expect to evert the lids and see if there's any follicular reaction, which I'd expect to see in a patient with allergic conjunctivitis. They would also usually be complaining about itchiness of their eyes. Usually with these patients who have allergic conjunctivitis, you also want to ask them, hey, do you have a history of atopy? Do you have seasonal allergies? Do you cough, sneeze during this time of the year? Has this happened to you before? This will kind of point you in the direction that, hey, maybe this is allergies. You could also develop contact lens intolerance, which can present as the eye feeling dry, irritated, burning. Usually patients will complain that they're finding comfort when they remove the contact lenses. And this happens to a lot of people who do have contact lens intolerance. Usually if you evert the upper lid, you may also notice changes of the conjunctiva. The conjunctiva is this layer that's overlying a membrane that's overlying the whites of the eye, which is called the sclera. So you can see that here, there's a layer of conjunctiva overlying the white, which is the sclera. So when you evert the lid, you'll actually see conjunctiva underneath the eyelid, and that conjunctiva can have changes, follicular, papillary reaction, depending on the type of reaction that the eye is undergoing. So with giant papillary conjunctivitis, generally you'll see giant papillae, and they're pretty big. And usually that tells you, hey, this patient may have an allergy to contact lenses, and contact lens discontinuation would be necessary to prevent this patient from having further reaction. Generally, patients who do have contact lens intolerance or GPC, giant papillary conjunctivitis, generally would need to be on contact lens holiday. They also need to be started on medications such as antihistamines, which will kind of calm down the reaction. Sometimes these patients do also need a low dose steroid. It doesn't necessarily mean that they can never wear contact lenses again. Patients can generally be put back into lenses, but not always. So that would be one of the other things. Chemical exposure is the last on my differential here. Sometimes having chemical exposure, someone who's used drops too frequently, or someone who had something splash in their eye can have a similar reaction as we saw on this patient, which is just the mild corneal finding of a superficial punctate keratitis. Chemical exposure, a lot of people don't realize that using lubricant drops or even using topical anesthetic drops can actually cause the cornea and the eye to really not be happy, and you can get several types of reactions. But one of the things that I have commonly seen, especially in the emergency room, is patients who have been complaining about dry eye or burning or some intolerance with their lenses. They'll just keep using their over-the-counter drops pretty frequently, and that tends to give them this reaction of the cornea, and they kind of take a huge step backwards when they do self-medicate or self-manage. So that's something else to kind of keep in mind. So a little bit more about dry eye. So causes for dry eye include contact lens use, and this is usually from years of wearing contact lenses. It generally doesn't happen from wearing contact lenses for a couple times a year, or wearing it for every day for only a year. It generally happens from patients who've been wearing it for multiple years. Other things that could also kind of exacerbate the symptoms would be someone who doesn't have good hygiene with contact lens use, someone who wears their contact lenses when they sleep, they don't clean out their lenses on a daily basis. Those are really, really important and kind of things to keep in mind that could make someone develop contact lens intolerance and then develop dry eye or worsening symptoms such as intolerance to lenses. Other causes would also include meibomian gland dysfunction. I'm not really going to spend too much time discussing that, but essentially it's called blepharitis. Blepharitis tends to occur in a lot of people, but at the edges of our eyelids, we have about 30 glands on the upper and lower lid. These glands secrete an oil substance. That oil substance protects the tear film. So it's the outer coating of the water layer of the tear film. And it's really important to have that layer. Otherwise, your tear film is going to dry out, and then you're going to have evaporative dry eye, and you're going to experience dry eye symptoms. So blepharitis can be a source for developing dry eye. It can also be a source for developing styes or chalazions. So blepharitis, again, I'm not going to discuss that too much, but it is pretty common. You guys should look that up because you'll definitely see it at some point during your ophthalmology rotations. Other things that could cause dry eye would include allergies, pregnancy, autoimmune conditions such as Sjogren's, thyroid eye disease has been associated with it, sarcoid has been associated with it, previous history of eye infections. So if you've had a corneal ulcer in the past, or if you've had some sort of eye infection in the past, even pink eye, you could develop dry eye in the future. A history of diabetes. Eye surgery has definitely been associated with dry eye. So any type of intraocular surgery, could be having cataract surgery, could be having LASIK or PRK. And those are the refractive surgeries that have also been associated with developing dry eye. And then lastly, I have on here is medication. So there's a myriad of medications that you could be on that could cause you to develop dry eye. This would include medications such as antihistamines, so medications that you may take to avoid developing allergic conjunctivitis or allergies. So antihistamine drops systemically, or antihistamine drops topically, or even oral antihistamine drops can make you develop dry eye. Other causes would be medications that you take for your blood pressure control. That could actually also cause you to develop dry eye. So just kind of other things to keep in mind. There could be a range of causes for dry eye, and it could be a combination as well. Okay, so there's a question here. Could dehydration play a role in dry eyes? It absolutely can. So when the whole body is dry, you can actually also experience some dry eye. Generally, if you're young and healthy, you're not going to experience that as much. But for somebody who already is baseline a little bit dry, dehydration can definitely help worsen the symptoms. So that's a great question. If you guys have more questions, do keep sending them my way. I'm happy to answer them along the talk. And then also at the end, I'll be answering a few other questions. Okay, so just a few, just to dig in a little bit about the symptoms or what patients may be experiencing when they come in complaining about dry eye. And it could be a range. It could be they're just complaining, hey, my eyes feel dry. Our patient came in complaining that they're having a burning sensation. Other patients may complain about a sandy, gritty sensation or foreign body sensation. That's pretty common. They may also just say, hey, my eyes are a little bit red. I don't know what's going on. I feel fine. Otherwise, I see fine. Patients may also have intermittent blurriness and a kind of a way to figure out is this dry eye associated, is just have them blink a few times and then try to read it again. And if things clear up, that's telling you the tear film is just breaking down so quickly that it's making them experience dry eye and blurriness in vision. Other things would include you may get a pulling sensation from the eye. You may even feel like there's someone pressing on your eye or pressure behind the eye. You may also experience tearing, and that seems a little counterintuitive. I have a lot of patients who always come in complaining about tearing from their eyes, and then when I tell them, hey, actually, this is all coming from dry eye, it seems very counterintuitive. But actually, the way that it works is when the eyes get extremely dry, it's the eye telling the brain, hey, help me out. I'm so, so dry. And the reaction for the brain is to cause these reflux tears. And the reflux tears are the tearing that we experience. So I know it's counterintuitive, but if patients are complaining a lot about tearing from the eyes, it's usually from dry eye. But of course, you have to rule out other sinister causes, such as actually having a foreign body in the eye, which can cause a lot of tearing. It could also be from trauma to the eye. Okay, so what can we do for dry eye? And this is kind of, there's an algorithm that you can follow to manage dry eye. And generally, each physician has their own kind of timetable that they follow. But for the most part, you're going to start off with over the counter lubricants. You can see here there's several different types. This is actually my favorite, the Refresh. It's preservative free, so you can see here there's a little vial. Those little vials are individual use, so you pop the cap, you use the drops, and then you kind of toss it afterwards. There's also other types, which are gel drops, which are a little bit thicker. These are, you have to warn your patients, can cause a little bit of blurriness when you instill these drops. The gel drops, they're absolutely wonderful because they will last in the eye a little bit longer than a lubricant drop, which kind of you put in your eye, gives you relief for a few minutes, and then it kind of dissipates. Gel drop sticks around a little bit longer, which means if it's sticking around a little bit longer, it's also going to cause a little bit of blurriness in the vision. So I always tell my patients, try this before getting behind the wheel or doing something where you need to see clearly, like working on a computer, because it's going to keep you blurred for a little bit. There's a thicker version than the gel, which is an ointment. I usually only reserve that for nighttime use because it's really, really thick and goopy. It can cause your lids to kind of shut at night. So you would wake up with crusting and you really have to battle to kind of open up the eyes afterwards. But this is really reserved for people who have really severe dry eye or patients who keep their eyes open a little bit at bedtime. And it just depends how much ointment you actually put in your eye. So the more ointment you put in, there's only so much space in the eye. So if you put too much, of course, it's going to kind of ooze out and kind of mat your lashes together. So ointments, again, I love them. They're absolutely wonderful. Particularly, they could be life-saving for our vision saving and can make patients really comfortable. But there are, of course, the side effect of having to use the right amount, causing blurriness in vision, kind of sticking around a little bit longer than you'd like. So a lot of things you have to keep in mind. And something I always have my patients try on a weekend or when they don't really need to see clearly the next day, just so they can see what their tolerance for the ointment is. There's also, of course, prescription eye drops. So that's after we've kind of tried all these other things, the over-the-counter medications. Prescription eye drops, that would be such items such as Restasis. I'm sure that you guys have heard about Restasis. It's kind of been around for 20 plus years. It's a great medication, especially for patients who have dry eyes, who are kind of refractory to the over-the-counter medications that we just discussed. Other things that I can offer my patients is punctal plugs, which is there's drainage channels in our eyes. So the tears that we produce, they drain out. And they drain out through the puncta that's connected to the nose. So when you cry, I'm sure you've noticed your nose gets a little bit stuffy. And that's actually tears from the eye kind of draining out into the nose. And so what we do is kind of plug that so those tears stay around in the eye longer. And this is really reserved for patients who, again, have dry eye that's a little bit refractory to the over-the-counter medications that we've already used. And so I would say that that's one option. That's usually one of the first line things. So usually I'll put patients on punctal plugs along with the over-the-counter medications. And I'll try those two combinations before I put the patient on the prescription eye drops. And then the last thing I kind of reserve for my patients is amniotic membrane. So this is kind of a purified amniotic membrane that's taken from obviously placenta, and then that's purified and cleaned and kept for use for ophthalmologists. I think a lot of other specialties also use this membrane, but ours is very thin and we put it directly onto the eye. And what happens is it dissolves into the eye. There's kind of a bandaged contact lens that kind of goes over this membrane. And once it dissolves into the eye, I have found that most of my patients find relief for about 3 to 4 weeks with that membrane. So I tend to offer that quite often as well. That's usually the reserved for patients who are refractory to everything else that we've tried. And that's all the stuff that we've discussed here too. Okay, so before I move on to the next case, I have a couple questions here. So for a patient with diabetic proliferative retinopathy on cauterization visits, should they use lubricant eye drops, or could this lead to potential consequences like increase intraocular pressure? So great question. Actually, I recommend using lubricant eye drops before going in for treatment. So like I've mentioned, there's several causes for dry eye, and this can actually cause dry eye. So patients who have diabetes are already kind of more prone to developing dry eye. Then you put them on the medications that they have to take to control their diabetes, which makes them a little bit more dry. And then they have to undergo treatments such as probably they're getting PRP for PDR, so panretinal photocoagulation. And that laser treatment can dry out the cornea because you're sitting for a long period of time with the lens on the eye, getting laser through that lens and through your cornea. So I actually do recommend lubricating before and after the treatment. Now, of course, it depends how severe your symptoms are before. So it would depend, what combination of medications you may use. But the preservative-free lubricant eye drops are really safe. You can use those every hour if you needed to. They're the ones that come in the individual vials. If you resort to using one of these other ones, which I'm showing down here, you are limited. You can only use that 4 times a day because they have preservatives in the bottles themselves. And if you use it more than 4 times a day, then you're going to end up having more severe dry eye than you would without using that. So just something else to kind of keep in mind, that preservative-free has really no limitations. You can use it every hour, every half hour, every 10 minutes. It's wonderful. But the bottled version of the over-the-counter lubricants or even prescription lubricants really, because it's bottled, there's preservatives in it, and you want to really be limited to 4 times a day. Okay, so the next question here, is there anything more new in the field as solutions for dry eye that doesn't contribute as much as environmental waste because these are just disposable? There's always new things coming out in the dry eye field. Absolutely, the single vial uses, I think about it all the time, that these are plastic vials that you're using on a daily basis, maybe using 2 a day. And actually those are recyclable. So if you're interested or if you're using those, I definitely recommend tossing that straight into the recycling bin so they can be used again in the future. They are starting to come out with bigger bottles that have new ways of offering preservative-free options without having to go through a vial each time. There's only a couple of companies that offer it. It's actually really, really expensive to get those, but you can get those as a prescription from your doctor, and some insurance companies do cover it. So if you're interested in kind of avoiding this wastage of using these multiple little vials, then you can kind of elect to use the larger bottles that have been approved for containing preservative-free drops and that are not as wasteful. So something else to kind of keep in mind. Other things is kind of treating the underlying cause. So dry eye, if there's an underlying cause such as a medication that you're taking, if you can switch off that medication, such as antihistamines, if you don't need it as much, then and you don't need to use it year round, then maybe you don't have to use lubricant drops as much during that time of the year. Other things would be trying different things like punctal plugs. I know a lot of patients are resistant to trying those just because I understand that it's an idea of having something actually go into the eye, which would be the plug, and it kind of seems that it would maybe cause you harm, but actually it's a really well tolerated procedure. There's hardly any adverse reactions to using punctal plugs. So I would say, keep those other options in mind. Punctal plugs are really, really great for some patients. Even if they've tried preservative-free tears, they've tried over-the-counter lubricants, gels, ointments, they might find relief from them, but it's hard to keep up with the maintenance. And I do understand a lot of my patients have a very busy lifestyle. I used to practice in New York City, so we're always on the go there. And those patients, sometimes they're better off using something like Restasis, where they have to use it in the morning and evening, just twice a day. And that's just one vial that you're using throughout the day to kind of get the relief from the dry eye that you're experiencing. So that would be another way. But I think probably the most important thing is to treat the underlying cause. If there's an autoimmune condition, maybe it's better to treat that. So if you have Sjogren's, you may need to be on some immunomodulatory medication. If you have underlying other autoimmune conditions, you may need to be on something like methotrexate or something that we work closely with rheumatologists to kind of treat that underlying disorder, which will also prevent you from developing dry eye. Okay, we have another question here. Which eye drop do you recommend for eye strain? Can eye drops cause eye infections or styes? So I'm going to answer those in two parts. So the first part, for dry eye, that's if you're young, you're healthy, and really it's from dry eye from staring at a computer screen all day, I actually would recommend first trying my 20-20-20 rule, which is essentially every 20 minutes, look 20 feet away and blink for 20 seconds. The problem with patients developing eye strain from staring at computer screens is that when we're staring at a screen, we're not blinking enough. The most important thing is to blink while you're staring at computer screens, because otherwise it's going to dry out. So generally you're supposed to blink 10 to 15 times a minute. They've done studies where patients are staring at computer screens and they're blinking maybe 5 times a minute. And that's really not enough. It's not allowing the normal tear film to kind of coat the whole cornea and coat the entire eye to protect it. And so that's what blinking essentially does, is every time you're blinking, the teardrop that's being produced by the eye kind of gets spread out with the blink of the eye. And so what I would recommend is that first try training yourself to be better about blinking. It's difficult. A lot of us grew up staring at screens and we don't realize we're doing it. But if you think about it, if you make a conscious effort, you can try to train yourself to blink a little bit more, give your eyes a little bit of a break, and you can avoid the strain that you're experiencing. If you feel like, hey, I'm doing all those things, I'm still experiencing a little bit of dry eye, it might be your environment. There's a lot of work environments that just have a lot of artificial air blowing, and that can also make your eyes feel dry. They can feel fatigued at the end of the day. Those patients, I actually do recommend, if you don't want to constantly be putting tears in your eyes, you can actually get a desk humidifier that can moisten up the air around you, and that can moisturize your eyes. But the most important thing is, of course, taking those breaks and giving your eyes that rest that it needs. So every 20 minutes, look 20 feet away, blink for 20 seconds, and that's going to kind of relieve some of that eye strain you're experiencing. If you're still experiencing symptoms, of course, then you can resort to over-the-counter medications, where you can even come in for a visit and you can have punctal plugs placed. So all the tears that you are producing naturally stay around a little bit longer. These plugs are really great. I just love them because they give such great relief to my patients. But there are two different types. There's plugs that are temporary, and there are plugs that are a little bit more permanent. The temporary ones, they can stay there from any time from 3 to 6 months. The more permanent ones can stay there for a year or even longer. So several options, and it kind of just helps keep the tears around. Actually, I would say the first time I learned how to do punctal plugs was in residency. Is one of the first procedures we learned how to do. And it was actually, we were all practicing on each other because we all were contact lens wearers, and patients who have contact lenses tend to be more dry than patients who don't wear contact lenses. And so we kind of practiced on each other putting in punctal plugs, and it was just a great experience. And that's when I became a true believer, because I felt my eyes felt so much more comfortable after putting the plugs into the eye. For the question with, can the eye drops cause infections or styes? So generally no, but there's a caveat to that. If you are using a drop where you didn't replace the cap immediately after use, the tip is dirty, the tip may have touched your eye the last time you instilled a drop in your eye, you can actually introduce bacteria onto the tip of the dropper. And so when you use the dropper again, you're putting that bacteria right back into the eye, which may have proliferated at that point since it's been sitting on a counter or being exposed to other environmental factors. So I would say generally, no. Eye drops should never cause infections, but it depends. If the tip of the dropper has been exposed, it's got some bacteria on it. If you've touched it with the tip of your fingertip prior to putting into the eye, that can also introduce some other bacteria, and that could then introduce that bacteria the next time you put it into the eye using that dropper. If you're using expired drops, definitely that's an absolute no-no. You should throw those drops away right away because you could cause a lot of harm to the eye by using expired drops. But generally, those would be the only things. There's, of course, exceptions to every rule. There's some people who are just very intolerant to drops, and so they may have a reaction to the drop or may have an allergy to the drop. And that could be the source of developing a sty, but generally styes and chalazions and hordeolums, all kind of within the same family, those tend to develop if there's been something clogging the meibomian gland. So this is what I was referring to, the blepharitis. Generally, patients with styes or a history of chalazion or hordeolums have a history of some underlying cause, such as blepharitis, which is essentially those glands that I was referring to at the edges of the eyelids, 30 on the upper lid, 30 on the lower lid, and any one of those glands that can get clogged. And then when they get clogged, they kind of back up and cause this development of a sty. Though that's generally, you have to treat the underlying cause, which is the blepharitis. And generally you can treat that with warm compresses, lid hygiene. I generally have my patients start off with baby shampoo. It's really well tolerated. It's gentle on the eyes as well. I generally have my patients lather up the baby shampoo when they're taking a shower, and with their eyes closed, just gently go across their eyelashes with a gentle scrub, and that kind of breaks down these clogged glands, and so you can prevent styes from developing that way. I would recommend doing that baby shampoo twice a day if you're developing a lot of styes, and then trying to do at least warm compresses once or twice a day for 5 minutes at a time, 5 to 10 minutes. All right, I'm just going to move on to the next case here. Okay, so this is case number 2. Patient comes in saying, my eye is really hurting. This is a 30-year-old male with decreased vision out of the left eye for 3 days. He's complaining about pain, redness, tearing out of the left eye. He's also complaining of worsening vision for the past 3 days. He denies any trauma, any similar episodes in the past, and no other complaints. His past medical history is pretty benign, but the only thing I did ask him specifically is, does he have a history of cold sores? So this is our patient. He has vision of 20/20 in the right eye, 2200 in the left eye. The pressure is 17 in the right, 22 in the left. Lashes are normal. The conjunctiva sclera, the right eye is normal, and the left eye does show diffuse 1+ injection. The anterior chamber for the right eye is quiet. For the left eye, there's a little bit of a reaction, so we grade that by cell and flare. So there's trace cell and flare. And then this is kind of the telltale for the infection that we're dealing with here. So for the right eye, it's a normal cornea. For the left eye, you can see this classic dendrite that's right here. This is with a fluorescein stain. So you put a greenish color or greenish yellow color drop into the eye, and then you shine this cobalt blue light, which is on our slit lamp, and that really highlights the dendrite here. So you can see here that this is a very characteristic dendrite. So this patient with an evidence of a dendrite generally only has one thing, which is herpes. So there's 2 different types of herpes infections, which you guys know, herpes simplex, and there's herpes zoster. And both of them can actually affect the eye. So I'm going to talk a little bit more about herpes simplex, because with herpes zoster, you're going to see a dermatomal vesicular rash on the face. So generally the patient's forehead and their face is being involved. If it's involving the tip of the nose, it's called the Hutchinson sign. That means the nasociliary branch nerve is being involved as well, which would mean that there may be an ocular component. There's a higher chance of herpes zoster ophthalmicus in a patient who may have the tip of the nose with a rash there, which is the Hutchinson sign. So that I would say we're not going to discuss further. This patient didn't have a rash. He's young and healthy. He just had this dendrite on his eye with a decreased vision. What we do know about herpes simplex is actually they found it in nearly 100% of the patients that were over the age of 60 on autopsy. So it's pretty prevalent, and we do actually see several cases of this every year. So I would say I see within my practice every week I probably have about one patient, if not more. And it tends to be seasonal, and we haven't really figured that out yet. But I would say that, herpes simplex is always on my mind in a patient who may have unilateral symptoms. The ocular herpetic disease can have a range of symptoms. So you don't always have this classic dendrite that tells you, yep, you have herpes. You may have just ocular irritation, but it's unilateral. The eye may be red. It may be masquerading. It may seem like this patient may just have pink eye or got something into the eye. They may just complain that, hey, all of a sudden they're intolerant to the lenses. And it's actually because they're having a herpes reaction in that eye. So you have to have a really low threshold for these patients if you can't really explain why the patient is having the symptoms that they're having, and particularly if it's unilateral. Other things is a full exam is necessary for the patients that come in with acute symptoms like this. And that's mostly because there could be retinal involvement, or could be anterior chamber reaction, or even posterior chamber reaction. So we have to do a thorough examination, even if there's a classic dendrite, as in there is in this patient, still have to make sure that the dilated fundus exam is normal prior to kind of managing and treating this patient. So this patient, a little bit more about herpes ocular infection. It's usually unilateral, really, really rare if you're going to find a herpes infection in both eyes. It usually can cause a range of symptoms. It can involve just the cornea, it can involve other layers or deeper layers of the eye. But if it's the cornea, you can get the characteristic dendrite sign, which is what we just saw, which is keratitis. You can actually get ulceration, which is the epithelial layer is missing, and that ulcer is kind of eating away some of the tissue, and we kind of call that corneal melting or corneal thinning. You can also get interstitial keratitis, which is you can get within the layers of the cornea a reaction without a superficial dendrite, or even without inner layer involvement. You can get the blepharoconjunctivitis, which is what I was referring to. You could get this follicular reaction where the patient's just complaining about ocular irritation, the eyes red, tearing, vision may be affected, but you don't have that classic dendrite with it. Then, of course, you have the classic dendrite, and there's a difference between the dendrites that you see in patients with herpes simplex versus herpes zoster. I'm not really going to dig into that too much, but just know that there is a little bit of a difference when we do take a look at it. But the other thing that's really going to tip you off is if the patient does have that characteristic dermatomal vesicular rash, then that's more of a zoster infection. And then what's really unfortunate that these patients can have recurrent episodes. There's been a lot of studies about the causes for herpes to kind of react and to reactivate. But there isn't any one particular thing for any one particular patient. So a couple of things that have been stipulated are sunlight. Sometimes sunlight exposure can cause the patient to develop a herpes simplex infection. Trauma to the eye, surgery to the eye can sometimes cause it. Heat, menstruation, stress, if you have trigeminal nerve manipulation, that can sometimes happen. And in patients who are immunocompromised, you may also see evidence of patients with recurrence of the herpes simplex. The symptoms kind of range. So you may experience blurred vision, you may have pain to the eye, you'll have some tearing, redness, and you'll have sensitivity to light. And this again depends on the type of infection that you have. So a patient who may just have a follicular blepharoconjunctivitis, like we talked about before, they may just experience a little bit of blurred vision or a foreign body sensation and some tearing, maybe some mild pain. You're going to start seeing more symptoms in patients who have the classic dendrite or interstitial or even anterior chamber reaction with cellular flare. These patients are going to be sensitive to light. They're going to have more decreased vision. So a lot of things can kind of range in the symptoms that they have based on the type of infection that they end up developing in the eye. The treatment for this, this is based off the HEADS trials. There's going to be, depending on the type of infection again, so if this is a patient with a characteristic dendrite, like in our patient, then I'm either going to start the patient on topical therapy or I'm going to start them on antivirals. There's some physicians that do offer both of them at the same time, but per the HEADS trial, which is this huge collaborative study that was done on herpes infections, said that you could do one or the other. You don't have to do both for patients with the classic dendrite for the eye. So these patients can be put on acyclovir. For patients with herpes simplex, will be on 400 milligrams 5 times a day. If you have zoster, you're going to take 800 milligrams 5 times a day. Ganciclovir and trifluridine, those are both really great medications. They're topical, but they're actually not always covered by insurance, and they're also extremely expensive. So those two medications, I kind of reserve and decide to use that patient on, or you decide to use this medication on these patients, depending on their insurance, depending on the symptoms that they're having. So again, ganciclovir is going to be 5 times a day topically, or trifluridine is going to be 9 times a day. Both medications are pretty strong, so I usually start my patients on lubricant eye drops as well while they're kind of managing this. This is not one of those infections that if you touch one eye and touch the other eye, you're going to spread it to the other eye. Fortunately, it doesn't spread like that. As I mentioned, usually HSV is unilateral. This is very different from the pink eye that you may experience. A lot of patients who come in think when they have these mild symptoms that they may have pink eye, which is viral conjunctivitis generally. These patients with viral conjunctivitis, it's highly contagious. So it's extremely easy to kind of infect the other eye. Things that I usually recommend to my patients, that if they're worried that they have a pink eye or they have viral conjunctivitis, you have to be extremely careful. Even using the same tissue to dab one eye and then dabbing the other eye with that same tissue, it's going to infect the other eye. And you want to be really careful because, again, with most infections, viral conjunctivitis can be extremely mild or it could be extremely damaging to the eye. So you can get vision-threatening infections from viral conjunctivitis. So I really do urge my patients to be really careful and keep in mind that, hey, this is highly contagious and it can be spread extremely easily. So even touching the eye and touching the surface, touching a doorknob can spread it to the person who touches it next. So, just kind of things to keep in mind, but not the same case with the herpes infection. It's not really spread that way. So, if there is active discharge, then there's viral particles within that discharge. And so you do have to be careful. So, whenever you're managing these patients, always wear gloves. I always treat these patients as they may have viral conjunctivitis until I can prove this is herpes. And then either way, I'm going to wear gloves and wash my hands afterwards. Okay, so let me see if we have a couple other questions here. Are blue light glasses worth it? So, there's a lot of hype about blue light glasses, and generally there aren't any studies that say that you need to wear blue light glasses when you're staring at computer screens or staring at your phone. They haven't really been found that they're going to protect your eye. Your cornea is actually pretty good at blocking most of that blue light. So I would say that blue light is not necessary, blue light glasses. All right, so this is case number 3. This is a patient who came in saying, my left eye is hurting. This is a 25-year-old male. He's a soft contact lens wearer, and he presents with pain, redness, photophobia, tearing, and blurriness in his vision for 2 days. He said that he does sleep with his contact lenses overnight. He denies any trauma to the eye, never has had similar episodes in the past, and has no other complaints. We look at his past medical history. You can see here that we're going to really highlight on this patient that he is a contact lens wearer. He does wear it out overnight. He last wore it a day ago. No other really other history here. So, whenever you're managing patients with contact lenses, you always want to ask them about their hygiene. So you want to ask them, when was the last time they wore their lenses? Are these lenses new for patients who don't wear dailies? If they keep them for 2 weeks, when was the last time they changed out lenses? A lot of patients are guilty of keeping their lenses for a month or 2 months when they're only meant to be used for 2 weeks. And the reason that this is so important is because protein bacteria kind of build up on this material, and the material is not really able to clear all of the buildup that's there. So using your contact lenses for more than the amount of time that is recommended can actually introduce new bacteria into your eye. So if you were to sustain any trauma, those bacteria that's sitting on those lenses can penetrate, enter the eye, and cause you to have a severe infection. So, things to kind of keep in mind, especially in contact lens wearers, is to find out what their hygiene is. Are they taking out their lenses every night? You should never be sleeping in your lenses. Even in the lenses that are approved to be used for overnight use, I actually don't recommend sleeping in them because I've just seen too many patients who come in for evaluation who have developed an ulcer from contact lens use and misuse. Always recommend wash your hands before you touch your eye. Definitely wash your hands before you take the lens out of your eye. And then you're going to put it in a clean case and you're going to use clean solution to put that lens in the case. So contact lens hygiene is really important. And you also want to ask your patients how they are managing their lenses and what their routine is, because that's going to help you decide, hey, could this be a contact lens related infection? So we look at this patient's examination, and you can see here that this patient's vision is 20/20 in the right eye, hand motion in the left eye. So hand motion at 2 feet essentially means that they're only able to see movement that's really close to their face, only 2 feet away. Otherwise, they're not really able to see from that eye. The pressure is normal here, 17 in both eyes. There's no abrasions or any evidence of any chemical exposure in this eye. Lids, lashes look normal. You look at the conjunctiva, the right eye is normal, but the left eye is extremely injected. So you can see here almost 360 degrees. This eye is completely red. Then we look at the anterior chamber. The right eye is quiet. And in the left eye, there's 1+ cell and flare. So there's inflammation inside the eye. And again, the anterior chamber is the space between the cornea and the iris, the colored part of the eye. So between that little area, you can actually see if there's a reaction. So this patient does have 1+ cell and flare. For the cornea, the right eye is normal. The left eye, you can see this kind of ring-shaped infiltrate here. And that infiltrate is what's concerning. And there's also edema here, so you can kind of see that. Can't really see the details of the iris that well through the cornea. The cornea is supposed to be a nice clear window, so you should be able to see the details very clearly when you're looking through a slit lamp. But in this patient, you can see that actually I can't even make out in the little areas that are clear that don't have this infiltrate. It's really difficult to look through there and see if there is any clearing. And that tells you that there's edema there. And once you kind of had the trained eye, you can actually see and gauge how much edema there is. So in this patient, they have 3+ corneal edema. And then there's superior neovascularization. So there shouldn't be any blood vessels on the cornea. And as you can see in this picture, this patient does have this neovascularization, these abnormal blood vessels kind of creeping onto the cornea, and that's concerning as well. And then you look with fluorescein stain. The fluorescein stain, again, is that drop that we used on that last patient, the herpes patient. You can see here that there is a large corneal epithelial defect. So fluorescein stain will also kind of dye areas that are missing the epithelial layer. And so you can see here clearly that there's a large corneal defect on this patient. So, again, this is a patient who's a contact lens wearer. So we're concerned for this patient. Several contact lens related injuries. This could be from overuse or misuse. The contact lens could have been kept on the eye for several days, and you can kind of develop this large corneal abrasion or corneal scar when you're taking out the lens, especially if the eye is dry. The lens can have adhered to the cornea, and when you remove that lens, you can develop this large corneal abrasion. This could be trauma, but our patient told us that he doesn't have any trauma. What's most concerning is that a patient who has some anterior chamber reaction, who has this abnormal neovascularization, this highly injected eye, you're thinking bacterial ulcer. An ulcer, again, is where you're missing the epithelial layer and there's missing tissue from the cornea. So you can see here that I don't know how well you can appreciate it in this picture, but you can see that there is a layer of tissue that's missing. So there's a little bit of a divot down here, and that's a large ulcer of the cornea, so a large epithelial defect. And that could be a bacterial infection. But the other thing that I'm really concerned about in this patient, because this is a ring infiltrate, it's characteristic for Acanthamoeba keratitis. And so what I did is always in patients who have ulceration, you always want to scrape this. So any patient who has an infiltrate, we're going to scrape it. We're going to send it for a gram stain and cultures, and you're going to try to see if there's a bacterial infection, waiting for the pathology report. So in this patient, actually, since I was concerned that this was Acanthamoeba, I sent the patient specifically for Acanthamoeba titers as well, and a Acanthamoeba workup. And you can see here that this classic circle is a characteristic cyst that you'd see in patients with Acanthamoeba keratitis. The cultures did come back negative, but a lot of times you do see patients who have let this infection kind of brew for a long time, and they may have super infections. They may have Acanthamoeba and they may have a bacterial infection. But fortunately, this patient has Acanthamoeba keratitis without a super infection. But generally, I do manage this patient with topical antibiotic drops as well, just waiting for the culture results to return, but in the meantime, to prevent a super infection from occurring. So what is Acanthamoeba keratitis? And this is, kind of an image that you guys can look at and study a little bit later, but essentially Acanthamoeba is a free-moving amoeba, a free-living protozoa. It comes in several forms, and the really scary thing about Acanthamoeba is that the cyst can really survive under adverse reactions for years. It can survive in environments for a really long time. What we have found that's associated with patients with Acanthamoeba is these patients don't really do a great job of storing and managing their contact lenses. They have a history of sleeping their lenses. They'll wear their lenses in areas where you may have exposure to Acanthamoeba, and that would include places like swimming pools, wearing your contact lenses in pools, in hot tubs, even using tap water in certain countries or environments. Using them in hot tubs, showering with your lenses. And again, this is all dependent on where the water source is coming from and if the water is contaminated. But essentially, exposure to water that may have protozoa, and this protozoa can live for a long time in their cystic form, can really expose you to developing Acanthamoeba keratitis. All right, so talking a little bit more about Acanthamoeba. So the most important thing is going to be diagnosing these patients early. So if the ophthalmologist has a high suspicion that this is Acanthamoeba, they're going to send scrapings like I did, and they're going to look for cultures for bacterial infection, but also look carefully if this patient has Acanthamoeba. These patients are going to be started on a really rigorous regimen. And what's really unfortunate is that bacterial corneal ulcers can be treated a little bit quicker than Acanthamoeba can. So if the patient does have Acanthamoeba keratitis, they're going to be started on medications. And these are not readily available because Acanthamoeba keratitis is not that common. Bacterial infections are a lot more common, especially in patients who are contact lens wearers. But definitely I've seen this in my practice. I see it at least once or twice a year. So it's not uncommon. And these patients need to be started on a combination of medications. So PHMB is usually the medication I kind of have been able to get access to. So I start my patients on that. And essentially that's actually pool cleaner. And that's a really dilute pool cleaner. And it's sterile prepared, and you're having to use this almost every hour while awake or around the clock, initially until the infection is starting to resolve. And then I also start patients with a combination of Broline if I have access to the Broline. So a combination of those two things usually do help my patients quite a bit to kind of relieve them of their symptoms, because this can be extremely painful. Would be to start them on cycloplegia, which will just dilate their pupil and kind of relax the muscle so they're not so symptomatic and so sensitive to light. Eventually, after months of therapy, once the epithelial defect has resolved, the patient may be started on topical steroids to kind of cause that corneal ulcer and corneal scars and the neovascularization that is developed to start decreasing. But the reason I put this presentation here is because it's not that uncommon. So if there's a patient who's a contact lens wearer who's not really responding to antibiotic therapy that you started them on, they may have something more sinister, such as Acanthamoeba kind of brewing there. And this just, my last patient that I had with Acanthamoeba keratitis actually had to have them on medication for a year until we were able to kind of get them stable. And again, what's unfortunate is that this can recur since these cysts can kind of survive for a long time in environments, even when they're exposed to the correct medication. They may still kind of rear their ugly head once we start removing them from the medication or tapering them from the medication. So a really scary process, and something to kind of keep in mind, and definitely in patients who are contact lens wearers who are not responding to the normal therapy. And these are my references. So thank you everybody for joining today. Again, I'm an ophthalmologist, cornea specialist in training, and I have some time to answer some more questions. So go ahead and send those our way and I'll be happy to answer them for you. Okay, so we have a couple questions here. Would you recommend contact lenses for a patient with diabetes, or is the risk of infection too high? How do you diagnose or do a physical exam for a viral infection? So again, a two-part question. Patients with diabetes can wear contact lenses. There's no harm in wearing lenses as long as you're doing all the right things to kind of protect yourself. So, the hand hygiene that we discussed before, that's extremely important. You want to make sure that you're washing your hands really carefully. You're using a clean case. You're not wearing your lenses overnight. You're using the contact lenses as directed. So you don't want to use them over 2 weeks if your lenses are the 2-week ones. If you're using dailies, definitely don't reuse those lenses. Really, really important to always make sure your hands are clean, your case is clean, you're using solution that's not expired. The tip of the bottle, if that solution stays clean, and you can kind of prevent yourself from developing an infection that way or having any problems. But definitely patients, unless there's some other underlying disorder or a source where you may not be tolerant to wearing lenses. My diabetic patients, I do let them wear lenses as long as they're being careful about it. The next question is, what exam do you do for a viral infection? So I think I mentioned that briefly, and I'll just kind of answer that again. You want to evert the lid. So you want to pull the upper lid and lower lid and flip it and just look under the eyelid to see if there's any evidence of a follicular reaction, which you tend to see in a patient with viral conjunctivitis. If the patient has EKC, which is epidemic keratoconjunctivitis, that's the really severe version of pink eye. The patient may have other findings, such as they may have a corneal epithelial defect. Some patients have ulcerations. Some patients do have pseudomembranes on the conjunctiva. These pseudomembranes actually can cause a lot of scarring on the conjunctiva, so they do need to be removed. And when they are removed, sometimes they do bleed. And so that's one of the other things you could look for. Patients with sequelae from viral conjunctivitis could include subepithelial infiltrates. And so generally, these patients are still going to come in complaining about blurred vision, sensitivity to light, despite having all the other symptoms resolved, such as discharge has resolved. And so these patients do have findings on their cornea that are these little infiltrates. They're sterile infiltrates, so it's not an active infection, but there's residual particulates left behind from a viral infection that can deposit onto the cornea. So these patients, unfortunately, do suffer for a little bit of time from viral conjunctivitis from that sequelae, but it can be managed with topical therapy. Surgical intervention is generally not needed. Okay, so next question here. Are the people aware when you do these tests? I always try to tell my patients that I'm performing this examination for this reason. I like to loop my patients in. I'm a huge advocate for patient education because I think understanding what's going on with your eye, with your health, is going to make you more acceptable for the treatment options and kind of understanding it a little bit better too. So if we took this last patient into consideration, I'm pretty upfront with the patient and I'm honest with the prognosis that it's guarded prognosis. I hope we can improve their vision, but it's going to take months of therapy. It's going to take them coming in to see me every week initially, and then we can start extending the visits once they've started showing improvement. With the patients with herpes, I always let my patients know that there is a chance of recurrence. If the patients keep having recurrent episodes, then I do let the patient know that I do start them on maintenance therapy, which would mean that they need to be on oral antivirals for long term to prevent having multiple infections, because these infections can be vision threatening. So generally, I think it depends on the physician, but for me, I generally explain every single thing that I'm doing to my patients, just because I think understanding what's going on with your eye and understanding what is being done and why we're doing certain things helps them understand it. And so then they have the reasonable expectations of how their eye is going to respond to the therapy or what to expect in the future. So I guess hopefully that answers your question. How do you deal with their eyes moving or blinking when when doing these. So this comes with experience, of course. So I would say, with most of my patients, I usually am pretty quick now, so it doesn't take me that long if I need to do a scraping or if I need to do anything. But if the patient's having a really difficult time, I'll either have my assistant kind of help me keep that eye open. And usually we use like a clean Q-tip or a cotton tip applicator to kind of keep the eye open. Otherwise, if the patient's still having a really difficult time, you can always use the eye speculum, which is kind of holding the eyelids open, and that gives me access. So especially when I'm doing scrapings, you're using a sharp instrument to remove this tissue from and debride the corneal ulcerated eye or the infiltrate from the eye. So generally, I'm a little bit more careful. I'll use a speculum if I need to. And it doesn't really hurt to use a speculum. It's a little bit uncomfortable. It's just keeping the eye open and wide, but it's a lot safer. So that's another option that you can use from keeping the patients from blinking. Generally, I have the patients focus on something. So have them look at my ear or my earring and kind of have them just look with their other eye, the eye that I'm not manipulating. So they're not looking around so much. Some patients do have a difficult time with that, but as long as you keep kind of redirecting them, then you'll be able to have them kind of stay still long enough where you can complete your examination. Next question here is, how often are you doing surgery versus treating cases like the past few? So I operate once a week. Generally, most ophthalmologists do operate once a week. So, I didn't put any surgical cases here. That would be going a little bit more in depth with ophthalmology. And next time, I would be happy to give a presentation on surgical interventions that ophthalmologists do. Because I'm a cornea specialist, I do spend a lot of time doing anterior segment surgery, which would include cataract surgery. But actually, my favorite surgery is corneal transplant surgery. Corneal transplants that kind of come in different breeds. So there's full thickness corneal transplant, also known as penetrating keratoplasty, which is essentially removing a full thickness layer of the cornea and using donor tissue to kind of put that back in place. Partial thickness corneal transplants, it could either be DSEC or DMEC, and there's multiple different types. But DMEC is essentially Descemet's membrane endothelial keratoplasty. This is working with tissue that's about 10 microns thick, 10 to 15 microns thick, thinner than a piece of hair. So really, really thin tissue that you're manipulating. Again, it's from a donor tissue. You remove the host layer of the endothelium and Descemet's and you replace that. And generally that's performed in patients who have Fuchs corneal dystrophy. So, a pretty common corneal dystrophy, and generally they don't have functioning endothelium. So these patients develop corneal edema. They can be extremely symptomatic, but the most problematic thing is that their vision has decreased. So for those patients, I would say DMEC really can be life-changing because they're able to see out of that eye again. As for a DSEC, which is Descemet's stripping endothelial keratoplasty, you're using a little bit of thicker tissue, and there's a little bit of stroma, which is a layer of the cornea that's also involved in that transplant. It's a little bit thicker tissue, so it's easier to manage. Generally, patients have excellent results with this as well, and it depends on the patient if they're a candidate for DMEC or DSEC, but those would be the different types of partial thickness corneal transplants. There's several other surgeries that can be offered. One of the other ones that I do pretty often are pterygiums, and those are those wing-shaped growths that come onto the eye. So I usually remove those, and that's a pretty quick surgery. And patients can find relief, within a day or two. And that's what's so great about eye surgery and ophthalmology is that a lot of these patients, you're not waiting, weeks and months and years to find that relief from that surgery that you gave them. With cataract surgery, they're going to notice the difference at that post-op day 1 or post-op day 0 when you see them, because you're removing this really large opacity that they're looking through, that lens that's really become too dense to look through and is then a cataract. And so these patients find just amazing vision changing effect from having cataract surgery. And similar with transplants, it's a little bit longer to change to see the effect of a transplant surgery. But usually within a month, you're going to have that patient seeing much better than they were before. And these are patients who had been struggling with blurriness in their vision for a long time. So that's what's so wonderful about corneal surgery or intersegment surgeons. What is my favorite part about ophthalmology? I honestly love doing microsurgery. As I mentioned, partial thickness transplant surgery is my favorite. DSEC, DMEC, I love doing those surgeries, especially because these are patients who have a corneal dystrophy that really have been suffering for a long time with blurred vision, decreased vision. They have a family history of it. And so really seeing these patients do well and seeing them see so well, it's really gratifying and really makes me happy that I'm able to help my patients out in that way. The next question here is, what made me choose ophthalmology? So for me, I actually knew I wanted to be a surgeon for a long time. When I started medical school, I had it in my mind that I was going to be a surgeon. Once I started doing rotations, I knew general surgery was not really what interested me. I felt the lifestyle was really not something I was looking for. So for me, I was then torn between the surgical subspecialties. So I thought about ENT, I thought about urology, and then I thought about ophthalmology. And what I would recommend is always going in with an open mind. I honestly thought I was going to be an ENT or urologist for the longest time. And it wasn't until my ophthalmology rotation is when I realized actually I love ophthalmology. And for me, I think what really attracted me to the field is the microsurgeries. I really enjoy doing microsurgeries. It's You're sitting during your surgery for the most part. You're working under a microscope. Not all ophthalmologists work under microscopes. Oculoplastic surgeons actually work with loops, and so they're generally standing when they're doing their surgeries. But for me, I really enjoyed the microsurgery, and that's what really made me interested in ophthalmology. So, what is your typical workday like? I would say generally Monday through Thursday, or however my week is, 3 to 4 days a week. I'm in clinic, I'm seeing patients. Things I kind of, you have to keep in mind with ophthalmology. Yes, there's your general bread and butter type of patients that are going to come in, your annual visits, your patients with dry eye. But then you could also have a patient who comes in with a history of contact lens use, and it could be anything from contact lens intolerance to this Acanthamoeba keratitis. So you really are at the edge of your seat when you're a cornea specialist with what might be walking through the door. You never know if it's going to be something that's just quick, that's a quick and easy treatment with starting them on therapies such as some topical therapy, antihistamine drops, and kind of seeing if that contact lens intolerance is the source of the patient's discomfort, or is it something more sinister, such as Acanthamoeba, and you're going to be seeing this patient on a weekly basis, if not more frequent. Bacterial ulcers, also corneal ulcers. You can see those patients every single day until that ulceration has healed. So, it can be, you can be at the edge of your seat, and of course these cases always come in Friday afternoon, so you have to be prepared for that. But uh, it's I would say my typical day, generally I see clinic patients from, and this is dependent on each ophthalmologist, but my schedule in particular, generally I'm seeing patients from 8 to 4 or 8 to 4:30. And this could be, again, like I said, a range of patients. Generally a half day a week. I also offer collagen cross-linking, and we didn't really talk about collagen cross-linking, but it's a procedure that's usually reserved for patients who have corneal ectasia, such as keratoconus. So, definitely check out my page. I talk a little bit more about cross-linking and keratoconus, but I do spend a little bit of time every week or every other week performing these procedures, in office procedures. And then you spend 1 day a week in the OR. And again, it depends surgeon to surgeon, but I generally have my schedule where majority of my time is in clinic, and then 1 day a week I spend in the operating room. And the operating room is my favorite part of it. It's kind of the time where you're just focused on the surgery that you're doing, and it's wonderful. It could be a range of surgeries in that day as well. It could be pterygiums, it could be a cataract surgery, or it could be a transplant surgery. So that's pretty exciting. Um, how has the pandemic affected you and your specialties? So that's an excellent question. Definitely we've had to slow down with the number of patients that we can see in a given time, just with the amount of space that we have in our practice. We have to socially distance, so we're not able to fill up the waiting rooms as much. Each room has to be wiped down before the patient steps into that room. And so that takes a little bit more time to turn over the rooms. I would say I'm definitely a lot more cautious with doing procedures. So generally procedures, when we're examining patients, you're less than a foot away from the other patient's face. And so I always am sure that the patient is safe and that I'm safe. Both of us are wearing masks, that the masks are being worn properly. So the exposure is limited to myself as well as my staff that are working with me. So it's definitely starting to ramp back up to normal, but we're working at a slower pace just to make sure that the safety protocols are in place, just because that's the most important thing, making sure that the patients are safe. We are now starting to test all the patients for COVID prior to bringing them to the operating room, because there's been a lot of studies that have shown that doing surgery, there's a lot of exposure to those particles going into the air. And so we're always testing patients prior to surgery to assure that the patients are asymptomatic and that they don't have an active infection. And if they do, then they need to receive the proper treatment. And then, of course, we'll elect to do that procedure later. This is, of course, not any emergencies. This is generally referring to elective surgery. Okay, so what advice would I give to undergraduate students who are applying to medical school? That's a great question. I think when you're applying for medical school, there's a lot of things to keep in mind. And again, please do check out my page. I have a lot of information on my page regarding this. But a couple things to kind of keep in mind is that I always get asked from students, what major should I be when I'm in undergrad? And honestly, there's back in the day, it used to be everybody was a biology, chemistry, or physics major, and it really just had that science background. But what I would say is, at least when I was applying, and kind of the trend that I've been hearing, is that patients who have more of a diverse background tend to be seen in a different light. So patients who, for me, I actually had a psychology BA, and I would recommend doing that after you've kind of completed all your pre-med requisites. So I did that all within my first year, year and a half. I had a lot of AP class credit that I had when I entered undergrad. So using that to my advantage, I was able to do a couple other things. So I actually ended up, like I said, with a BA in psych. I actually had a minor in creative art, and I started doing a lot of business classes as well. And so that kind of really gave me that opportunity to expose myself to other things. This is your one opportunity, because afterwards, all you're going to be focusing on is in science. And so I would say, do your pre-med classes early. That's probably the most important thing, but have some flexibility, try out those things that you've been thinking about or have wanted to try. I would say I have zero regrets. I'm so thankful that I did my creative art my creative art minor, because it really gave me that chance to do something that I'm so interested in. Painting, pottery, working with metal, woodworking. It was just really exciting. And I'm so thankful that I had that opportunity, because now in the future, when I do have time, I have these hobbies that I can fall back onto. And even if it's not something that, you're not doing it for the future, you kind of just want to check it out. I think I did take a jazz class once just to kind of learn that music and that style and learn more about that history. And so, college is the time to have a great time to experience lots of different parts of the world, the culture. So I would say take that opportunity, but the most important thing is to make sure that you're getting good grades. So making sure that you do your pre-med classes early, your prerequisites within the first 2 years or first 3 years, and then kind of digging into other things that are interesting to you. Grades are extremely important. I couldn't emphasize that enough. Being someone who has a background, let's say I had done a major in creative art, and it's pretty time consuming to do creative art because you have to do a lot of outside the classroom work. That I would say is not going to show as highly on my transcript or my resume versus it, and if I didn't get great grades in my prerequisite classes. So, other things such as extracurricular activities or other things that may look really, really great or may have made you extremely happy. It's good to take those experiences, but definitely you want to make sure your grades are high, because at the end of the day, they're not going to spend time looking through your transcript and saying, oh my gosh, I can't believe this person did this, and this. And that's so great that they did that. Honestly, they're going to look at the bottom line, which is your GPA or the grades that you got in those prereq classes. So really focus, make sure that you're spending that time making sure you're getting good grades, because that's extremely important. That's going to carry a lot more weight than your extracurricular activities. And speaking of extracurricular activities, I was the person who loved being involved in a lot of different things. But I would say it shows and it carries a lot more weight involved in an activity that you can show leadership skill in. So if you're a person that also loves doing lots of things, so I was participating in so many different clubs and activities, but that was initially, and then kind of when my junior year, third year rolled around, that's when I realized, hey, I really don't have time to be involved in all these things. And it's a little bit better to show that you're a leader in one or two, or a couple of activities versus being a member in like 15 activities. So I would say spend that time wisely. It is a limited amount of time, so it's better to be a part of a program or a club where you have some leadership roles, and that way you can show that you have these qualities, these leadership qualities, which is what committees are going to be looking for applications on their students' applications, to make sure that you have the leadership skills to be a part of their medical school, be a part of establishing yourself as a physician. So leadership activities, any clubs that you're involved in, you want to make sure you're always stepping up. So you're using your time wisely, and you're making sure that you're getting to that point where you have that presidential, or you have that vice president or some sort of executive council role in that club. And that's going to carry a lot more weight than being a part or just a member in 10 different extracurricular activities. Other things I'd kind of keep in mind is that when you are actually doing your application, you want to make sure that you have someone who's giving you a great letter of recommendation. So this is advice that I had never received, and I personally thought I'm going to get a letter of recommendation from the biggest name in our school. And although that person may not know me as well, I thought, hey, that name carries a lot more weight than anything else will. But the reality is actually that letters of recommendation are going to be carrying a lot more weight when the letter is a strong letter of recommendation. So a strong letter comes from a person that knows you well. So I would say choose the person correctly for you, someone who knows you really well, who's going to write you a stellar letter of recommendation, versus the other person who may write you a generic letter, because you may not know, but there might be someone else who's applying at the same program, at the same school, who also got the same generic letter that you received. And that, I think, won't carry as much weight. And when people are reading hundreds of letters of recommendation, the letter of recommendation that stands out, the one that's really highlighting you and your qualities, that's going to carry a lot more weight than a generic letter. So definitely keep that in mind. And I have a lot more on my page about that as well. So definitely check that out and let me know if you have any questions about it. I'll just answer one more tidbit here, and then I'm happy that I was able to have you guys join me today, and hopefully this was helpful to you to get an exposure to ophthalmology. So I'd say, what else would I recommend for applying to medical school? I would say, keep an open mind. Your personal statement, your CV, those are going to be extremely important. Personal statements, spend a lot of time working on that. You want to brainstorm. I would say, it's not something that you're going to be able to write overnight, or it's not going to be written well if you do it quickly. I personally started brainstorming pretty early on. You want to tell a story when you're writing your personal statement. So if you're trying to highlight a quality such as you're hardworking, then you want to make sure that you show them that you're hardworking. Don't tell them that you're hardworking. And kind of an example of, or a way to do that, is to tell a great story. So you want to start off by saying, starting your personal statement by showing them that here's a story about how I'm showing you that I'm hardworking. You worked with the patient from the beginning to the end, or you picked yourself up when you fell down quite along the way when you're trying to get to a certain goal. And that just shows them that you're hardworking versus telling them that you're hardworking. So, kind of just putting a blanket statement out there that I am hardworking. it's not going to carry as much weight, or they're not going to remember you as much, versus if you tell them the story about how you managed a patient or you went through these obstacles to kind of get to where you are today, and that shows them that you have perseverance and that you are hardworking, is going to be much more memorable than kind of just listing out your qualities. I would say you also want to start this by doing a attention grabbing kind of way to start your personal statements. It could be a quote, it could be a story. There's a lot of examples out there, so I would definitely check them out. But definitely have multiple drafts to your personal statement. You want to make sure that you've reviewed it multiple times. You want to make sure that that you've had this that you've given this time to dedicate to your personal statement, because it's really going to help you show the program that you're a great candidate. They already have all that information about your CV, through your transcripts, about how you have good grades, what your scores are in your MCAT. Both of those things carry so much weight, but your personal statements, your time to put a name to the face and kind of have a story behind it. So take that opportunity to really make sure that you're highlighting the qualities you want to highlight that are not seen on your that are not seen on your CV or your transcript. You don't want to repeat yourself, so take that opportunity to really show a different part of you and highlight different parts that show them that you're an excellent candidate, a strong candidate, someone that they would definitely benefit from having you as part of their program. Um, all right, guys, I really, really appreciate you guys joining us today. I hope this was helpful. Check out my page. I'll show on here. Again, if you guys want to join me on Instagram, I have a lot of things you can check out. I have a lot of posts about pre-med. I'm pretty excited to be able to offer advice. I know this stuff wasn't available when I was going through the process, so hopefully there are things that I'm able to help you guys out with. Or if you have other questions or want me to put posts on other things, definitely send me a message. I'm happy to answer those questions or put a post about it. And thank you again for joining me, and good luck in the future.
Thank you so much, Dr. Patel. It was an honor to have you here today. Everyone, make sure you check out her socials. And thank you everyone for attending. As I'm sure you have seen, the Google form has been posted in the comments and the Instagram bio. If you could fill it out within the next 10 minutes, we'll close it after then, and that way we'll be able to receive verification for your attendance. Thank you so much again, everyone.